My name is Faustina Mensah. I'm a student at the CSU Pueblo School of Nursing. I'm pursuing a course in Masters in Nursing with emphasis in education. This recording is part of the instructions strategy classes Nursing 576. So this is part of the teaching part of the course, and I'm going to teach today to a mental health class, students preparing to be do their masters in nurse practitioner and the psych mental health NP class, and this is part of their pharmacology class. So the topic for today is bipolar type 1 and treatment. The objectives for this class, I want students to be able to know that bipolar disorder, it's a major mental health disorder, and students to understand what this disease is, the statistics and relevance of bipolar disorder, learn how to make diagnosis of bipolar disorder, and learn how to use a pharmacology to treat bipolar disorder using the current guidelines. At the end of this course, my expectation for students is that they will understand bipolar disorder and make timely diagnosis. Also, students are expected to use current practice to prescribe medications for patients based on their history. So let's have an overview of bipolar. What is bipolar disorder? According to the National Institute of Mental Health, bipolar disorder is classified as a mood disorder characterized by dramatic shifts in a person's mood, energy, and activity level, which indefinitely can affect a person's ability to perform activities of daily living. So these are some statistics on bipolar. So there is 2.6% of adults resided in the United States have bipolar disorder. 82.9% of these 2.6 cases are classified as severe. So most of these patients can be seen in the hospital at any time. It affects approximately 5.7 million adults in America, and according to the World Health Organization, bipolar disorder is the sixth leading of the cause of disability in the world. Now, the relevance is that it affects an entire life of an individual, the families, and the community as a whole. It's an important illness to monitor by ensuring that pharmacology treatments are effective. The latest evidence does show that people are adherent compared to the past to pharmacological treatment. And pharmacology is the cornerstone of bipolar disorder type 1. The emphasis here is on type 1 because people with type 2 can go without medication. As we go on, I will explain the difference between type 1 and type 2. So we need to emphasize that with bipolar type 1, we need some sort of medication so that the patient will be able to function well. Bipolar disorder is a mental that can affect anyone at any age. So cases have gone under the radar, and sometimes it's misdiagnosed because of the symptoms they present can mimic symptoms of other diseases. A major mental illness that is seen in the United States, and it's carried genetically. As I said, it can affect the whole person, and it can be prevalent in a certain location. Many patients living with this mental illness are seen in the hospitals daily. So reasons for the admission mainly is the side effects of their medications. It's not working well and they stop taking it. There is lack of funds to purchase medications. So some people don't take it because there is no money. Especially where I work at Denver Health, we see a lot of patients in this category. And medication, they feel the medications may not be the right thing for them. They think they are doing okay. They don't need the medication. And here they stop taking them, and then the disease, the symptoms comes back. So let's talk about diagnosis. So there is a manic state. So according to the DSM 2010, there is a manic state, and it has to be about at least 7 days or more unless the person is hospitalized. It interferes with their life greatly. There is increased mood, there is increased energy, there is decreased sleep. So that's the manic. There is an hypomanic state. So there is 4 days or more of the symptoms. Somewhat interferes with their life, but this one is more of depression, sort of, and same symptom as the manic, but it's interfering with their life, but at a lower pace here. It's important to differentiate between bipolar type 2 and Azus type 2 from bipolar type 1. And here is the main difference. In bipolar type 1, in the there is a manic state. So the manic state, the patient is out of control. The patient is doing all kinds of things. So for someone to be diagnosed with a bipolar type 1, there should be at least one manic state in their lifetime. And this manic state, so they are out of control. There is increased energy. They are not sleeping. They are cleaning. They are yelling. So we have to have that. Once a person can show that they've had that once in their lifetime, then they are in bipolar type 1. When there is no manic state, but we have the hypomanic and everything else, then the person is having bipolar type 2. Our emphasis on this lecture is on bipolar type 1, and we'll have bipolar type 2 on another day. So the therapeutic objective is to focus on acute stabilization with a goal to bring the patient to a symptomatic recovery to a stable mood. On maintenance, the goal will be to prevent lapses and reduce threshold symptoms to improve social and occupational function so that the person can go back to work. The person can function well at home as a mom or a dad. The person can function well at church, wherever they are. So this is the APA guidelines. So the primary goal of treatment for patient experience a manic or missed episode is symptom control to return to normal level of psychosocial functioning. The rapid control of symptoms such as agitation and aggression may be particularly important for the safety of the patient and others. Treatment is aimed at establishing a stabilization of the episode with the goal of achieving remission defined as complete return to baseline. So this is critical, that the patients will return to their baseline without all these manic episodes. So the APA guidelines give us a clear understanding of what interventions to put in place. So the intervention will be to start a new medication like valproate, also known as Depakote, that will have a first-line treatment agent that will not have the kind of side effects that patients was experiencing, really. Or lithium. So it has to be lithium, or it has to be Depakote, one of these two. There'll be a need to add a psychosocial treatment like CBT, cognitive behavioral therapy to such a treatment. So normally people do a lot of cognitive behavioral therapy for bipolar type 1 and then with the medication. So the two together, it's expected to help. So if social therapies are used, they should be combined with pharmacotherapy. And pharmacotherapy is the cornerstone. So the only indication for psychotherapy alone for patients experiencing acute manic or mixed episodes are when all established treatments have been refused, involuntary treatment may not be appropriate, and the primary goal of therapy is to focus on crisis management. So these are the main medications that we will be doing. So the first line pharmacological treatment for severe manic or mixed episode is the initiation of either lithium plus an antipsychotic or valproate or Depakote plus an antipsychotic. It's critical that treatment decisions are based on knowledge of the potential side effects and the benefits of these medications. Treatment should be continually reassessed, of course, with the patient to make sure they are taking it and to make sure that side effects, we are given other medications to take care of the side effects. And then there's a lack of insight or minimization It's often prominent with bipolar type 1. And sometimes the patient may not be able to make the right decision, so we'll have to bring family involved. Then there is evaluation of the bipolar type 1 to be careful to make sure that clinical history and assessments are being done as much as possible. So these are the medications that we use. For mood stabilizers, we have lithium and Depakote, and these are first-line treatment. Lithium is the oldest medication, so either lithium or Depakote, depending on the patient's history, is what we normally use. And then we have antipsychotic medications like Abilify, Risperidone, Zyprexa. These medications are normally used in addition to the first-line treatments like lithium and Depakote because this one acts really fast. The Zyprexa is a very quick, that helps with the manic state, and then with the lithium or with the Depakote, whilst it takes time for lithium and Depakote to start working, so the antipsychotics normally comes in to help, whilst the lithium and Depakote once they start working and we get to the therapeutic level, sometimes we might stop using the antipsych medications and then just keep the patient on lithium or Depakote, or they will use these antipsych medications as needed. We also have antidepressants like Prozac, sertraline that we can also prescribe. There is also serotonin reuptake inhibitors that sometimes may be used. There are other medications like Cymbalta, Salicylic, and other medications that we can use. But the main ones I've seen used is the lithium, Depakote, or the antipsych medications. So we have a case study here, and the details is really, we have a patient here, Mrs. Lawson, who is a 45-year-old marketing executive, and he's showing symptoms of bipolar type 1. The issue here is that he's not taking his she's not taking her medications. She started having serious side effects. She stopped taking them, and now she's here at the hospital. What do we do for her? So she's on lithium now currently. What are we going to do? From her history, we can see that she is experiencing bipolar type 1. She's having all the symptoms. However, she stopped taking her medications, and now she's here. Most practitioners might take her back to lithium, but we cannot. The guideline is telling us that we have either lithium or Depakote. So between the two, we can now start her on Depakote, and then look and see how the side effects will go, and then from there we can go from there. So in this case studies, this patient will take her off lithium because, of course, she's having a side effect. She stopped taking it. We'll put her back on Depakote. We are going to add some Zyprexa, and hopefully her symptoms will stabilize. And there will be a need for her to do some therapy. And then once she stabilizes, she can go back home. And the goal will be that she'll follow up with her PCP. Pretty much. So this is the conclusion of this teaching, that bipolar disorder 1 does confer considerable functional disability to the individual, their family, and the society as a whole. It's an important factor influencing bipolar type 1 is really the non-adherence to pharmacological agents, and in that people do not tolerate the side effects of their medications well. So even if they are on good medications and they are not tolerating the side effects well, it's not going to help them in any way. So we have to find out that they are taking the right medication. As psych mental health nurse practitioners, we have to select medication that patients can tolerate well and be effective at the same time. And we also have to follow practice guidelines closely to make sure we are doing our best for our patients. That's the end of this recording. I hope you will enjoy this lesson, and we'll continue with bipolar type 2 another time. Have a great day.